Hey everybody, today we're going to be talking about gestational diabetes mellitus. And I'm just going to go ahead and start by the CDC's definition, which is a type of diabetes mellitus that can develop during pregnancy in women that do not already have diabetes. So today we're just going to be going over the epidemiology and pathophysiology, some complications, the clinical presentation, the diagnosis and the screening protocol, and then the treatment of GDM. Now we're going to go over the epidemiology and pathophysiology of GDM. It affects approximately 6% of all pregnancies in the United States, with the incidence rising in parallel to the increased diagnosis of metabolic syndrome, which, as we all know, is high blood pressure, increased blood glucose, central obesity, and abnormal cholesterol or triglyceride levels. The prevalence also varies among race and population characteristics, with African American and Hispanic women being the most commonly affected populations. So now we're going to talk about the pathophysiology. And in a normal pregnancy, insulin resistance evolves during the second trimester. So it is normal for insulin resistance to develop, but it becomes abnormal whenever the pancreas cannot compensate for the increased levels of multiple hormones, those being tumor necrosis factor, human placental lactogen, and human placental growth hormone, all of which are hypothesized to contribute to the development of GDM. So basically, as your pregnancy continues, your pancreas must be able to compensate for increased levels of those hormones, and if it doesn't, then you can develop GDM. So basically, why do we care? That's because it can cause severe complications for both the baby and for the mom, and those are going to be talked about on the next slide. So now we're going to go over the complications of GDM, and although these are separated into fetal and maternal complications, they all kind of overlap, and you'll see that throughout the slide. But for fetal complications, the most important would be macrosomia, which is a baby larger than 8 pounds and 13 ounces despite their gestational age. And it's known as one of the most important complications because this excessive fetal growth can increase both mother and fetus morbidity. So basically, if the fetus is too large, it can't go through the pelvis and can cause shoulder dystocia, which then can cause an emergent and unplanned C-section, which of course is bad for the mother. And also the shoulder dystocia could cause permanent damage to the fetus. We're going to go over shoulder dystocia more on the next slide. But then for fetal complications, it also could cause childhood obesity and then other birth defects. And then for maternal complications, there's always the risk that the mom could then develop diabetes mellitus after their pregnancy. So because of that, the mothers are going to be screened for diabetes 6 to 12 weeks postpartum and then every 3 to 5 years. Other complications for the mom are going to include gestational hypertension, which then can lead to preeclampsia and eclampsia, and then once again that unplanned and emergent C-section if the mom does get eclampsia. Okay, now just a little bit more about shoulder dystocia, which once again, shoulder dystocia is when the baby's anterior shoulder gets stuck on the mom's pubic symphysis, which is dangerous for both the mom and for the baby. And it's dangerous because it could cause umbilical cord entrapment, the inability of the child's chest to expand properly, which both could lead to severe brain damage or death due to hypoxia or acidosis because of the delay in delivery, and also brachial plexus damage. And brachial plexus damage could later lead to Erb's palsy, which is a paralysis of the arm caused by injury to the upper group of the arm's main nerves, which is the brachial plexus. And Erb's palsy can be treated in a child with physical therapy if the child is started on a treatment regimen early in life, but it also can progress to permanent damage if the child does not receive physical therapy. So now we're going to get to the clinical presentation, which, let's be honest, there's not really a clinical presentation for GDM because it is asymptomatic. So what's important for both the mom and for the clinician is to recognize risk factors and encourage prenatal care. Risk factors for developing GDM are going to be obesity, glycosuria, family history of diabetes, impaired glucose tolerance, being Hispanic or African American, fetal macrosomia as a part of their birth history, low HDL cholesterol, and a personal history of metabolic syndrome. So there's a lot of risk factors, but I put some on the screen that I felt like were the most important ones. So any patients who possess any of the risk factors are typically going to be screened at their first prenatal visit instead of the typical screening time, which we'll talk about on the next slide. So if they get tested at their first prenatal visit and everything's normal, then they're going to be tested again at the normal screening time of 24 to 28 weeks gestation. Then, if their screening test is positive, then they'll be diagnosed and started on a treatment regimen. So we're going to further discuss the screening guidelines on the next slide. So now we're finally to the diagnosis, which is going to be based on a screening protocol. The diagnosis and treatment of GDM is made by looking at maternal glucose values, which is unlike the diagnosis of type 2 diabetes, where you guide treatment with hemoglobin A1C. So GDM screening is going to be done at 24 to 28 weeks gestation, unless you have those risk factors we already talked about. But typically, what you were going to be looking for is 24 to 28 weeks. And most commonly used is going to be the two-step approach, where the patient has a screening test first and then a confirmatory test. So the screening test is going to be a 1 hour, 50-gram oral glucose tolerance test. If that test is positive, then the patient does a confirmatory 3-hour, 100-gram oral glucose tolerance test. There's thresholds for abnormal glucose values, which are steadfast, and if one crosses the threshold, then the patient's going to be diagnosed with GDM. But all those numbers are kind of tedious, so we're not really going to go over them right now. But what you need to know is there's going to be a screening and a confirmatory test, and those tests are the 50-gram oral glucose tolerance test and the 3-hour, 100-gram oral glucose tolerance test. So we have finally arrived to the treatment, and GDM can both be prevented and initially managed with both diet and exercise. And like type 2 diabetes, aerobic exercise is preferred for those with GDM. If diet and exercise does not control the blood glucose values, then the mother needs to be started on insulin to prevent the complications that we already talked about. I'm about to throw a few numbers at you, but the one that you really need to remember is that the target for blood glucose is going to be less than 95. But other numbers that are important would be a blood sugar value of greater than 105 fasting or 120 postprandial, being indicative of the mother needing insulin. But even once the mom has started on insulin, the blood glucose target is going to be less than 95 for good control. So insulin is the treatment of choice because it doesn't cross the placenta, but glyburide, which is a sulfonylurea, and metformin have also been studied and deemed safe if insulin is for some reason contraindicated for the patient. So now for the neonatal assessment. This kind of varies from institution to institution, but most clinicians are going to monitor the fetus in some way once they know that the mother has GDM. So this can be done by either serial ultrasounds to monitor the fetal growth rate or fetal non-stress tests that begin around 32 weeks. But the goal of that is going to be to reduce maternal and fetal complications. A lot of practitioners also will induce the mother at 38 weeks gestation with the option of a C-section if the baby is known to be macrosomic. And that is it. Here's my works cited. And thank you so much for listening.